So welcome to healthcare in the digital age. Let's start with the idea of big data, which is a recurring theme at the last few global conferences. What is it? What challenges does it present? Opportunities for all of us? How is it changing medical science? Historically, when we thought of patient data, it was held in the doctor's office. Increasingly, it is viewed as the patient's property, to do with as she pleases. How is this mindset changing healthcare and medical research? Anna, why don't you start us out?
So good morning, everybody. So Mike, thinking back to 2003, which you may or may not remember was the completion of the sequencing of the human genome, which at the time everyone said would probably be the discovery of our time, and I think that's proving to be the case. So since 2003, we have figured out that disease is really information. It's digital information. So we've learned actually since that time of having sequenced the human genome, which by the way cost around $3 billion.
3.8 to be exact.
But who's counting? Yeah, who's counting? So today you can get your genome sequenced depending on where you go. Patrick can do it pretty reasonably, actually. A lot of people can.
Well, we say 1,000, but Patrick, what's it going to cost eventually?
Well, it depends what you're asking about. And you know, it's not the human genome. I'm going to be controversial here. It's actually the proteome, which you have to go one step deeper than the genome.
And it's also your biome, because we want to see what you're eating. Anna?
So if you'll pull up slide 2, I think what I want to do with this slide, essentially, slide 2, if you look at where we are in medicine today, that digital revolution is well underway. So if you look at the top of that slide, we're now dealing with lots of devices that are going to deliver enormous amounts of big data. And now we're talking about moving toward almost unfathomable amounts of data coming into the medical system. So it's breaking down into what the president talked about recently, my area of interest, precision-based medicine, and then information-based healthcare, which is what every patient will have control of in terms of this whole M-Health idea. Everybody's got one of these, right? Everybody, let's see how many of these are in the audience. How many? How many? Everybody has 2, right? So more than we have on the planet in terms of people. But you know, I found out I bought a Fitbit, Mike, that I paid for a Fitbit. Then I figure out I have it all on my phone. Exactly. So I wanted to get my money back after that. But if you look at this, it's all producing enormous amounts of data. It's going to give us insight not in just to the molecular basis of disease, but we now have to take that data that's coming from patients on the M-Health side, the precision medicine coming on the other side, and all the devices that are wearables, the kind of always-on wearables that we're all going to be wearing, some of us are already wearing, is producing an enormous amount of data, unfathomable. But it's probably the revolution of the century, because essentially, once we learn how to monitor big data and mine big data, so monitoring and mining is going to produce, I think, unprecedented understanding of disease. And when you have that, we'll stop talking about episodic treatment of disease and start talking about wellness and real advances in terms of health.
Thank you. And Anna, in 1995, we recruited Anna to lead our research efforts on something that became known as the March, and our efforts to double the NIH budget, triple the NCI budget, increase the CDC, the National Science Foundation. And Anna led us with understanding the issues at that time, then went on to head somewhat strategy and innovation at the National Cancer Institute, and has been a leader. And today, you can read all about her in your programs, is leading this effort from Arizona State. Atul?
Sure.
Big data.
Yeah, it's big.
You've gone from Stanford to UCSF to change the world. We have 2 sessions on precision medicine later in this week. Talk to us about little bit of your background, because it's coming from a different direction,
Right.
and how you and UCSF are going to change the world.
Yeah, so when I think about big data, I think of, big data actually comes from small packages. So I always bring my little prop, these little gene chips with me, Tells you something, if they're that cheap, I can carry them in my pocket now, right? With a chip like this, I can just measure an entire genome. If you go to slide 14, you can see what these really look like in real life. And when you get tired of measuring them one by one, you can measure them almost 100 at a time on the right there. And this is just one of many of these types of technologies we have in life science research. If you go to slide 15, you see the sequencing side of it, where, again, you've heard about these numbers, but you realize the Genome Project was done in massive centers like the one on the left there, and we're literally heading towards getting sequencing done on USB sticks. It's a no-brainer. This is going to affect medicine and impact medicine. But actually, the most impressive part of this, and how I got my start in this career, is actually on slide 16. It's amazing we have scientists using this. What's really impressive is, for some reason, based on the journals and the funding agencies, we actually make scientists share this data on the internet today. And that, to me, is the most amazing revolution of them all. That it's one thing to have smart people having great measurements and knowing what to do with them, but when you open this up to the entire public, it's another level. This is a news report in August of 2012, when we got to 1 million of these chips publicly available, 1 million of them. 15,000 prostate cancer samples, 50,000 breast cancer samples. To me, this is the most amazing export from the United States, actually. We could export this data to a high school kid in Baton Rouge or Bangladesh, and they could come up with a drug that they would sell back to us for $1 billion, right? What an amazing concept. So to me, it's not just about the data, but actually opening up to the public, to citizen scientists, as well as real scientists.
Atul, when I was at Berkeley in '65, I had access to the CRISP tapes and data of financial history.
That's right.
As a student, I could access this information freely. I could test my theories on capital structure and what happened. In medical, historically, creating data sets might cost $100 million. What do you mean by frozen data? You constantly talk about that. And what will be available to the graduate, PhD, MD student in the future?
Yeah, I mean, so when I think about data, I think of data as frozen knowledge or frozen action. Data by itself, we can talk about the infrastructure and the cloud computing and all that, but that kind of wears on you. It's actually what do you do with the data that's actually exciting. If you go to slide 17, it's my kind of token example of what we can do with this kind of data. So many people use these types of measurements now to study diseases like cancers, heart disease. So many people use these kind of technologies to study drugs, whether psychiatric drugs or cardiac drugs, that you can kind of match.com the two together, right? The data is already publicly available. This example where we figured out that a psychiatric drug, an antidepressant, seems to reverse the effect of having small cell lung cancer, right? You get that from smoking, 5% survival rate. These are mouse lungs. They don't have to smoke to get this kind of cancer. You can knock out some genes for this to happen. And on the right, you can see the nodules on the left. On the right is the same kind of mouse treated with an antidepressant. The cancer is melted away. So this is an example of drug repositioning, again, using public data to do this. Well, this is work done by graduate students. And more impressively, they can launch companies on this, not just write papers about it. And to me, that is the next big direction for us in academia, is to take the science into the private sector. If we want to change the world, we can't just keep writing papers about it. This is how open data really enables that.
So by getting this open data, Mitch Daniels, the president of Purdue, has now arranged for, starting as a freshman, you can get your own IP. So if you want to start addressing some of these issues. So let us step back, if we could, for a moment, and go over to you, Victor. You had a demanding job. First, we want to say hats off to Duke for national championship.
Yes, here, here.
You've moved to the Institute of Medicine. Why don't you just give us a couple minutes on the Institute of Medicine for the group and your decision to go there to better leverage what's available to us today?
Sure. So the Institute of Medicine is the health arm of the National Academy of Sciences. In fact, there are 3 academies, as you know: science, engineering, and medicine. And for me, it's a great opportunity to work with my colleagues here to say, how do you take great technology, great advancements, and really make it work for the patients and for the providers? So what we do a lot is both in terms of working on policy side with Congress and with the agencies, but also with the academic side with different individuals, and we convene people together, such as a panel like this, perhaps with patient advocates and FDA and others, to say, how can we all make all this work? So for me, it's running a health system, which in fact is on the ground doing the kind of things you're talking about, to how can you do this nationally and globally?
So we're going to take a 1-minute video break here and show, there's a new Star Wars movie coming out. And we're going to show you a sequence from what was the second release, but now known as number 5, when Luke lost his hand in a fight with who turned out to be his father. So can you run that video back there?
It is useless to resist. Don't let yourself be destroyed as Obi-Wan did.
Now let's look at 2015.
Now pick it up with, yeah, that's right. Clever boy.
The hand that we developed for amniotic band syndrome children and adults is driven by the motion of the wrist. When you bend your wrist forward, it makes the fingers close, and you bring it up, it opens the fingers. With the MakerBot, as he grows, all we do is we scale it up and print him another one, and the hardware just gets taken from that, put onto the new hand, and then we'd like those hands returned so that we can then filter it onto the next person. The MakerBot and being able to swap files up and down via the internet cut our sort of prototyping down from a week down to 20 minutes. It was incredibly fast.
I am actually quite excited of having a robo hand. I'm excited to try cricket, golf, and go swimming with it.
It's amazing.
I can pick up stuff.
I couldn't imagine what it would be like if I had it.
I can throw a ball.
My friends think it's awesome.
I like my robo hand.
So technology is changing, and as we all know, what was science fiction becomes reality. John, you've taken on a number of challenges in your life. You were extremely successful. In the previous one, I made a terrible mistake of not investing the minute you were hired. Many people thought BlackBerry's days were behind them. We all knew the minute you took that job that the world was going to change. Talk to us about BlackBerry, the future of BlackBerry, and the role that you see BlackBerry playing in this data revolution in medicine.
Okay, thank you. That was quite an introduction, and one that is tremendous pressure here. Anyway, I joined the company 18 months ago, and I thought it'd be with the technology that BlackBerry has, and especially in the areas of security and privacy, we thought that would apply to do something useful, and then have the company reposition to do well in that. So one of the major areas, and this is why I'm on a panel here, is on healthcare. And it's really gratifying to hear all the testimonial here about, you know, healthcare embracing science and technology and IT and everything. And so our job is to focus on transferring those data around and making the best use of the data, whether it's big data analytics or knowledge-based analytics, securely. around the world. And as you pointed out, TWO has this device that you basically represent a person.
That's right.
And people. And this is an information extremely well sought after in the black market. And you know, I was told once that bad people may pay you $50 for credit card information, but they'll pay $500 for your personal health information, and maybe upwards of that. So, and there's a lot of very infamous hack in the industry, whether it's from the insurance company, whether it's on the healthcare hospital side of the equation. So we are out here to solve that problem. And it's not and that's why when people ask me, why do you get into device business? And I said, well, the device, if it does something purposefully, which my buddy here has, and it will help advance this mission. It will help our company and it will help the world. So this is where we're focusing on, and that's part of the overall arching strategy of that.
What are the stumbling blocks that slow innovation? And in this social media age, are people getting more comfortable, do you feel, in getting that information out there? We know they're willing to go on a talk show and tell the entire world every secret of their family, their relationship with their wife, etc. But how do you find this today with your devices?
That's great. That's a great question. So let's go back on a couple of issues. I think it's pretty broad-based. First of all, in order to embrace the data analytics of everything that's being created every day around the world, there is no standard on that communication. There is no API, for example, and that prevents great apps to be produced, and we're still in that framework. Secondly, government have different policy around the world that may or may not allow that simple transport, export, import of the discussion. And thirdly, most people are struggling with financials in the healthcare business, and they're not really investing in something that doesn't see instant return. As far as an individual concerned, this is the one most puzzling part of the world, the equation. People thought they put their, like myself, when you do the e-commerce some 10 years ago, you put your credit card on the system, on the internet, and you kind of like hesitated, then you put it, eventually the convenience kind of have you force over the hump, and now your information is on, your credit card information is on the internet. Now, you'll feel comfortable with it because somebody backstop you. If you reported your credit card being under fraud or stolen or misused, you don't have any liability, so as an individual, you're very comfortable doing that. Except healthcare is a little different. Your personal healthcare information, disease and genome information, are not something that you're replaceable. It's not like I give you a new numbers, and it is you. So I still find people willingly to put everything about themselves on the internet. I know my daughter does it, so extremely puzzling. And so, but all I could do is let the market come to us, and the market will come to us. All these hacks, I believe, literally, the Anthem hack on Blue Cross Blue Shield affects 100 million people. Right. 100 million people. I mean, maybe I exaggerated a little bit, but we're not far from that, right. from that number. So reputationally, it's a big hit. People feel uncomfortable with entering that system.
Mm-hmm. So Patrick, we have a panel here about technology advances that will blow your mind. You've done this a number of times. We've asked what the lab of the future looks like, what the hospital of the room of the future looks like. What will the doctor experience interacting with the patients? Now, by the way, John, I have to tell you, I love my new BlackBerry Classic. It's fantastic. So, great product.
Thank you.
Patrick, why don't you start us out and tell us, you have been a person who has not been shy to think differently. and question the norm.
Well, I think...
Why don't you take us to the future?
So, I think what's exciting is that the future is actually here. It just needs the courage of the medical community to actually adopt it. The challenge, I think, the biggest challenge, I was being asked this by the American Medical Association, what is the biggest challenge now with advancement of 21st century care? And I think, sadly, the biggest challenge is dogma. We have to actually unlearn everything that we've learned before, because we as physicians have been trained to understand diseases from an organ state. So you're a breast cancer specialist and you're a lung cancer specialist. For the first time, we can now understand diseases at the cellular state. And if you look at cancer, they don't care which organ they're in. If you have a cellular biology that's happening, whether it's in lung or breast, the same drug could apply, even a non-cancer drug, which is called repurposed. So if you look at the issue that I'm now challenged with, when we developed Abraxane, people didn't realize that what we were understanding then, and this is 1990s and got proved in 2005, that cancer is but a dance of proteins in your human body. So that if you could address a protein that was ubiquitous to all cancer types, you would have a drug that would treat all cancer types. And Abraxane was a nanoparticle that actually went after a single protein in the blood vessel that expands in all tumor. And that's why today it's approved in breast cancer, lung cancer, pancreatic cancer, and people are surprised. It's taken me a decade to get that insight across, and I believe even today people don't understand how the drug works. By 2005, I began to realize that as 2003 happened and President Clinton and Tony Blair stood up, and I think Francis Collins was in the room, and rightly so, was so excited by the fact that the human genome had been isolated. The concern I then began to sort of see is that we don't treat cancer at the genetic level, we treat cancer at the proteomic level, which means you need to get beyond the human genome. You need to go from these 3 billion bases all the way down to the RNA, to the protein as 2 million proteins to find the one. And it's like the Matrix, are you the one? So that you can actually then target a therapy to that protein. All our drugs today are developed towards target therapy towards a protein. So the country was not set up yet to do proteomic analysis. The country was not set up yet to look at patients in a way, because when you get down to the proteomic level, you find that cancer is a rare disease. It means there's no one single institution, the Dukes of the world, the UCLAs of the world, the Harvards of the world, will not have enough patients with that particular proteomic profile to compare outcomes with each other, which means there wasn't a learning system available in the nation, which means that you needed to then capture the human body in real time to look at the outcomes. And I happen to have been fortunate to be, not many people know, that as a UCLA surgeon, I also was a NASA scientist. So I got a grant from NASA, and part of the Abraxane stem cell program was as part of a shuttle program. So the vision was, why wouldn't we make every human being on the planet an astronaut? Why wouldn't we be able to actually communicate and capture the vital signs of every human being in real time? And with mobile technology, we can do that. So the first thing we needed to do was build this system of this connected device that would talk to every medical device in the nation. We're now in 350 hospitals, connected to hundreds of different, whether it be IV drip, a ventilator, emergency room, and capture the vital signs. I call this capturing the human signal engine. The next thing you need to do is actually transport that kind of box, which I'm working with BlackBerry and Verizon and AT&T's, into the home as a next generation set-top box that wirelessly communicates that system. If you did that, you'd then have the NORAD of healthcare, which, by the way, we're now creating across the nation, where you create a mission control center. So that's the first part of just capturing your vital signs. But now all of a sudden you have an opportunity to go deeper, not just from your vital signs of the physiology of the human being, but down to the cellular level of the cancer or at the genomics level, which then says, talking about big data, every human being, every time you interrogate the patient, it's a terabyte of data. Now, if you talk about 10,000 patients a day, that's 10,000 terabytes a day. We are already at 4 petabytes. We probably now have the world's largest database of healthcare data on the planet. We're about to go to, we'll probably hit the first healthcare system organization to be at exabytes. So the
the panel, we want them to know in the audience.
What's an exabyte?
How many zeros?
Okay, so 1,000 megabytes, if you understand, a megabyte is a terabyte. 1,000 terabytes, 1,000 gigabytes, I beg your pardon, it's a gigabyte. 1,000, I've lost my zeros, right? 1,000 gigabytes is a terabyte.
Right.
So you're talking about 1,000 terabytes. So we're talking about levels of data that is unfathomable. So the first thing is the country did not have an infrastructure to move this kind of data, which means you need to move data, we calculate it at tune of 6 terabytes a second. So one of the next steps was to build an infrastructure to be able to move that data at 6 terabytes.
So let me just give a measure here, if I could, Patrick. 30 years ago, I'm in laboratories at Warner, and they're trying to figure out, will people buy a DVD? It takes 2 DVDs to hold 1 movie. Will they put it in, then have to go and flip it over, take it out, put another one in and flip it over? 1985 in America. Korea has announced their new G5 efforts, where they estimate you'll be able to download a movie in 1 second. So things that Patrick is talking about are partners with technology. You needed speed, you needed data storage to be able to hold the world's largest files, human beings' medical records, who you are digitally. Have you been able to solve that problem, Patrick?
Yes, we have, actually.
I just wanted to know.
That was a setup. I fell right into it.
It was a setup.
It was a layup.
No, but in all seriousness, so we've created now, and that's what we're working with BlackBerry and the BlackBerry Enterprise.
What brought the 2 of you together?
When I started working with BlackBerry before John was the CEO, and tried to speak to the previous founders about the fantastic infrastructure, the security system. And when John came on board, I made the first phone call, literally, that week, and we just knew that this was the path, and John, this was his vision, to take this on. So the BlackBerry has this well-established security system. We have then, because the next phase is not just creating connectivity and dumb fiber channels, but to create what I call supercompute machine learning artificial intelligence. And I don't call it artificial intelligence, I call it augmented intelligence. So in parallel, we were building supercomputers that could interrogate the human genome down to the proteome almost in real time, because you need to deal with 2,000 to 3,000 patients a day. Today, for you to take a gene panel, and the panel chips of 500 genes, and then take it to 22,000 genes, and take them to 3 billion, takes 2 to 3 weeks, maybe 4 weeks to 5 weeks to do that analysis. That's of no good to a patient that needs the treatment decision in 2 weeks. It's even worse because the treatment itself is going to affect the gene sequence, and as you repeat that, you need the effect of your own treatment on that gene sequence. So from a practicality perspective, you need to also build a supercomputer, which we've built. The next thing we need to actually show in scale that you can actually do this, and at ASCO, and I can't do that without messing up.
Now, do you have a real-life demonstration you could show us here, Patrick?
I will. I'm trying to make sure I can show you this. But before I show you that demonstration, let me put you the basis of that. If I can go to slide 21. So this is where I do see the future. If you can now interrogate every cancer cell, not just at its genomic sequence, the gene, but what the gene, as it mutates, translates downstream to its protein sequence, which means its antigen. What we've now discovered is every tumor cell expresses that antigen that is unique to itself and even to the rest of the human body of that patient. So imagine then if you could do that in real time and then go seek out an antibody to match that. And if there was a quadrillion human antibody sitting in the library, which there is, and then pull out that antibody to match that antigen, all of a sudden you would have a targeting moiety to that cell. Well, it turns out, what would you then cause to kill that cell? You and I have in our bodies a cell called the natural killer cell. It represents 5 to 10% of the human body's white cell count. And it's there, what we call innate immunity, circulating around, waiting for either virus, hepatitis, shingles, measles, or a cancer cell to come around and activate this natural killer cell. So why is your natural killer cell not killing your cancer? It turns out it is. The scary thought is your body is probably producing tumor cells every day, and your human body is actually killing it. But as the tumor gets smart enough, it actually silences this natural killer cell and puts it to sleep. So imagine if, in fact, you could take a natural killer cell that could not be silenced, put it into an antibody, and target it. Next slide, please, 22. You would then have what I call an activated natural killer cell that could then target the tumor and release its granules, and on the right-hand side, kill the tumor. That natural killer cell now exists. We have now built the cell, and now you could have, this natural killer cell line, we believe, is God's gift to mankind here, because it can be able to go after not just tumor cells, infections, and stem cells, and we can have what I call a living drug in the blood bag. Which means you need to then monitor the human being, not just at the astronaut level, but at the molecular level, so that you can actually, just in time, create this next generation manufacturing. So I'm going to show you a video which has not been seen before, if I could just describe it before it starts. The left-hand side, you see green cells. These are breast cancer cells, human cells, that are normal. The right side, the red cell, is a HER-positive cell. It has an antigen on it. Imagine taking a natural killer cell that has a targeting moiety that will seek out the red cell and kill it. If you could play that first video on the left. And seeking it out, it's not touching the normal cells, and engulfing and killing the positive breast cancer cell. That same natural killer cell on the right-hand side has the ability to be a serial killer. If you look at the next slide, and that future is not the future, that future is here. We've now done this in 40 patients.
That's right.
We have a patient with Hodgkin's, complete response. We're about to launch these phase 2 trials. So the future, you asked the question of the future, is we need to take molecular medicine at its most precise level, down to the protein, transfer that kind of information into a machine learning tool that could adaptively learn the outcome, tied to the physiome of the patient, the vital signs, the heart rate, the blood pressure on a daily basis, and then integrate that into a mission control center.
So let me go to Anna for a moment, if I could, Patrick. Anna, one of the things we've dealt with, you and I, for the last 20 years, has been standardization of data. Patrick has told us if we could get the data. What are the efforts? What do we need to do about standards of data? How do we get people around the world to meet some standard?
So that's an interesting question, isn't it? Because the world is pretty disconnected when it comes to data. So the medical care system is probably the most disconnected. T.S. Eliot said, you know, hell is where nothing is connected. Those of you that think the medical system is hell, in large measure, that's because it's not connected. And when I was at the National Cancer Institute, we tried to actually begin to create the kind of interoperability that we're going to need to achieve the kind of thing that Patrick has just talked about. I mean, in a digital information age, everybody has to have access to the same information. So if you know part of the genome or part of the proteome, as Patrick has just said, you don't know enough. So the issue, I think, on a national level, Michael, is I think this isn't a problem that I think a single individual or a single laboratory with the best intentions, can solve. I think this is one where we need some government help here. Europe has actually a pretty big initiative. We have several initiatives now in this country. Francis Collins and I did something called the Cancer Genome Atlas, where we sequenced 20 of the major cancers, and we had one database for that. And we had probably 150 institutions in that, and they all put their data in one database. So that kind of started our thinking about big data and how you can actually assemble it. But I think we need something more at the top, and you always like to give people something to think about when they leave. We need to fix this data and interoperability problem. I think, Atul, you know this as well as I do. I call these data tombs. We do hundreds of clinical trials in this country. We never see the data. The data never comes out of those tombs. The private sector does trials, the government does trials, the agencies do trials. The other thing is, how good is the data? All data is not created equal. And so a lot of things that we learned, for example, in the Cancer Genome Atlas, we had to actually go through and set data standards. And I should tell you, I mean, if you read The Economist, you already know this. This was on the front page of every single major magazine last year and journal. We're having problems with reproducing a lot of this data across the scientific community for the reasons that we've just talked about. If you're a silo and you essentially are publishing a paper and it's an experiment where you have bias or you have a problem, then that becomes data that's in the public domain like all the other data. I'm particularly interested in biomarkers, where we have reported about over 400,000 biomarkers have been reported in the literature. Do you know how many we approve every year? FDA approves every year? Yes. Less than one. So the reason for that is very complex. The science is very complex, but we're going to have to do a better job at sharing data, because at the end of the day, what Patrick told you, it's not about getting the genome or the proteome or the transcriptome. It's about the analysis. And you know, the analytics here, all of you that have children who were glued to their cell phones doing all those games all those years, they knew game theory. They didn't quite know that they knew game theory, but that's a new generation of science that's going to change everything. So Richard Feynman used to say there's plenty of room at the bottom. That means that there's still a lot of room at the bottom. So all of you that were sure that you were going to give up on your children as being hopeless, these are the ones that are going to start the new companies to actually fix this data problem. So this happened to me recently with my grandson. You know, I thought, no chance, but he became a great biomedical engineer based on everything he learned in analytics. So I think there's hope.
Atul, different generations have different ideas of what bioscience is. What will the lab of the future look like?
Well, I think the lab of the future, I mean, it's intuitive. Playing with this kind of data is a lot more fun than dissecting frogs like we teach high school kids about in biology. I mean, this is
What does that chip cost?
This is probably $200, $300 now, but the data is already there even, right? We have standards problems, but we also can fix them by just having more people generate more data, more eyes on data and more sources of data, right? The most beautiful thing about data doubling every 2 years is actually half the data is only 2 years old or younger, right? I mean, these are fresh hands generating new data. We have to share more. I think the clinical trials aspect is a big one. I know the IOM is working on this as well. European regulatory agencies are more apt to get the data shared compared to our own institutions here, but I think it is a source. The lab of the future, I think, is going to start with data before they pick up a pipetter. They're going to start with data before they design the next clinical trial. I don't know if you're showing this picture right now, but I just want to point out, so this is, inadvertently, I didn't see this until right now, but this is a before and after, by the way. The one on the right was the before. I got my Fitbit, and the one on the left is 50 pounds lower, actually. So we didn't coordinate this, but that's a before and after. It's after and a before, of course. But so the data does influence behavior. Those kids playing games are also subject to gamification. Companies that we're not thinking of right now know how to influence behavior. Those are the ones that are going to actually get us and gear us towards better behaviors, too.
Victor, are today's researchers in step with the idea that data should be shared broadly?
Well, you know, I'm listening to this conversation. I say, I'm just blown away. I'm a researcher myself and actually worked in precision medicine and others. But I'm thinking about how to get from this technology phenomenal breakthroughs to how we can do it every day. So earlier, we talked about big data, and we talked about generating evidence from this big data. I don't think today, at least among our scientists, people really know what that really means.
Right.
Because traditionally in medicine, you think about randomized clinical control trials. That's proof. Placebo versus treatment and the whole bit. And here you generate a huge amount of data that connected with each other. And what's the standard by which you can say that's good enough to make decisions? That's evidence. I think that's one area. And certainly we're looking for next generation, and people like Patrick do this. The other one, of course, is got to do with today's scientists. And today's, we haven't talked about healthcare. Today's healthcare providers, are they ready to be able to really manage all this information? And you probably all read about John Wagner's book on the digital doctor and talking about where they are today versus where we should be. And believe it or not, he pointed out that, in fact, you don't want physicians and providers to become data clerks. You need interpreters. You need monitors. So we have to add that layer of capability within our health profession and be able to use it effectively to make those kind of decisions. So I think there's all that to be done. As a physician, as a scientist, and as someone who ran a health system of doctors, nurses, et cetera, I think we have some work to do. The kind of work you guys do is just phenomenal. You can just plug in and find out what works, what's not, but the people on the ground still have to be able to learn how to work this. So those are some of my thoughts in listening to this.
Victor, I think this is a very important part. There were 14,000 urologists in America. And most of them were not up to date. They were giving the best advice to their patients, but they weren't necessarily up to date on modern technology and what was going on. And so as we had these scientific retreats, beginning in the early 1990s, everything that went on was put up on the web. And we discovered at a point that 50% of the people coming to the site were doctors. And they were coming there because their patients were coming in with information and asking them.
That's right.
And I think, how do we change this issue of people that went to school, to medical school, before we knew there were genes? And I think the challenge to realize that after you've set up all these research areas, that I'm a kidney doctor, I'm a lung doctor, etc. Now you're being told that someone with a glioblastoma, as Patrick has told us, has more in common, okay, with someone with a kidney disease or melanoma than they do with other glioblastomas. And so, as we've seen science, I think this is what Patrick has told us, to paraphrase it, as we've divided things up, it's going to be different in the future. So, John, tell us about your interaction with Patrick. How did that go?
On what level? Personal, social?
Let's try all levels.
Okay. No, I mean, Patrick obviously had a lot of brilliant ideas, and how we get...
But you're responsible to make them work, right?
Well, I don't know, but
or collect the data.
Yes. What I'm trying to do is to build the most secure communications systems for mobile. And
we've seen that many of the government employees are switching back to BlackBerry.
I hope so.
So they don't get to read their emails in the paper in the morning.
That's right. And I think as recent as the weekend, New York Times had an article regarding the President Obama, at least, when people were trying to hack into the systems in the White House, the unofficial system or the unsecure whatever systems that couldn't get onto the president's BlackBerry, so that was a good thing. Thank you. Anyway, we have a lot of common ideas. I mean, I'm obviously not from the clinical side or the medical data side, But we know, at BlackBerry, we know that what a lot of our technology in privacy and security, it's not just security, it's the privacy part, could definitely apply to the medical world. And the medical world is quite disjointed. Sorry for, I'm just a kind of a layman looking at it.
It is.
It's very disjointed. No two countries have the same systems. Even within a country, the systems are designed not to talk to each other. And so even with electronic medical records, there's a lot of different definition. And talking about sharing data across the world is virtually impossible.
Yeah.
Right? So we're trying to solve some of these transport issues, both in the secure side and the mapping side. And then so happen that what Patrick is really doing is modeling. I mean, he's using statistics to help model treatment, right? And he's not really creating the treatment, he's creating a model for the treatment. And it fit perfectly into what we believe that would be a tool that is useful for the whole healthcare industry. So that's why.
So Patrick, is this 10 years away? Is this 5? I see you're holding your BlackBerry here.
So,
what do you have on that?
So it's actually here. So as John said, the key to the data is not the static data, it's the dynamic data. Meaning you and I sitting here from the hour you started and the hour you're leaving the room, dynamically your body, your molecular system is changing. Imagine in disease, the disease is actually changing on a week-by-week basis based on the treatment. So therefore, all this data that's stored in this health information systems is useless to us from the day it's actually stored there. So which means we need to create a dynamic monitoring system where we can capture in real time the data and then put it into a supercomputer, what they call predictive modeling machine learning tools that could say what should be your next treatment, like your Mercedes-Benz that you're taking to a dealership. We could be engineered in that way and it's real. But once you've done that, how do we empower both the clinicians who are not trained in this way, and more excitingly, I believe, we're going to do not patient-centered care any longer. Within a year, my goal with BlackBerry is to create what I call patient-empowered care. Because to have the patient have that information, as you suggest, at their fingertips, but responsibly real information that they could share with the doctor about themselves at the molecular level, at the genomic level. So what we have here, and we'll be launching this soon, this is the passport, and John and I become hand models now soon.
Yeah, I got one too.
But if you want to see this, I'm not sure if you can bring your camera to it, but we've been able to load now not only the human genome on this, so everybody's human genome down to the single base pair. So which means then, this is, let's say, a patient and a doctor sees it, and you literally tap on it, and you would literally now go right onto this patient's genome. And then through the cloud, here's this patient's genome, and through the cloud with yet another single tap, you tap and go to the cloud and get into the abnormal base pair in real time, right down to the machine read, right down to the drug that should be given to that patient, right down to the clinical trial that's available. The good news is now the software, the SaaS software, has been adopted by Anthem Blue Cross. And it's now throughout the state, 50 states in the United States. So this tool then will soon be basically the Google Maps, so to speak, of the human genome. So what I think about this is a way to think about it in today's terms. Imagine then that we could create the molecular address of your cancer, and I called it GPS. So we could GPS your cancer, find the molecular address. The next stage is that we need to find the Uber of healthcare, using the target of the antibody and drive that with the cancer natural killer cell. And this is your device to actually call on that Uber. So this is real. This is about to be launched. The idea of having security embedded inside the system, tied to big data, tied to real-time dynamic data, tied to physiological data, tied to molecular data, is not a fairy tale. And I think the rapidity of which this is going to be launched will surprise you.
All right, so we're in wrap-up mode. So Victor, a couple questions here. What is the Institute of Medicine doing to help patients become better stewards of their own records? And two, We know it's easier to build than to rebuild. What can we learn from other countries? You've traveled the world in this role and about empowering patients through data.
Yeah, I took a look at how many initiatives we're doing at Institute of Medicine on data, on digital health, and I came up with more than a dozen.
Yeah, easy.
That means we're actively working on this issue. I mean, that's what we do. We bring together people to say, here's the gap. You heard this. I mean, phenomenal science to how do we make it work? And so we have roundtables on health literacy. You know, we talk to patients and they say, you know, we don't even understand the fundamental ABCs of healthcare, to some of the knowledgeable people who can tech savvy, right? There's a big gap. And how do you achieve equity in this case? Now, talking about globally, you know, huge amount of middle-income countries all have access to iPhones and mobile phones, and they're using it. That improves equity. On the other hand, in our country, we're very worried that the vulnerable population and those who really are culturally different, you know, diverse in this case, have actually feel there's a tremendous gap in terms of access to these technology. So we bring people together to talk about and ask questions how to move forward. We have advised the government on what should be in the electronic health record for meaningful use 3. What do you incorporate so that information is being used now by everybody who's going to have to follow electronic record standards. We have recommended to ONC about standards by which vendors have to come in to meet certain standards, particularly in capturing data and being able to be useful. So we do a lot of things like that, and I certainly see that in traveling the world. I would say that, as pointed out earlier in your session and others, that you know, sometimes you don't have legacy systems. It's better. You can actually start new and get it right. We have a lot of work to do, but at IOM, you know, you talk about clinical data sharing. We have a major report that came out on data sharing. 23 sponsors, including pharmaceutical companies and NIH and others, said, this is what we want to do. How do we share data together and make it known to everybody? So that's what we do. And I'm very encouraged by the technology here in terms of bringing it to societal benefit.
Let's take a quick poll, Anna. How many people in the audience have a wearable device today measuring something about your body? Okay, we're going to do that every year. We'll probably be at 100% in 5 years. Anna, you've been in government agencies. You're at a university today. What is the most exciting thing you're working on today?
So I work on a lot of things. It's a tough choice.
That's why.
It's a tough choice. But I think probably the most important thing that I see happening, and I'm doing several things to enable this, is how do we actually take all this molecular data, this genomic data, the RNA data, the proteins that Patrick talked about, et cetera. We're learning a lot about the function in disease. What we need to now is to have all the patients engaged, because what you don't understand, or maybe you do understand after this session, is when we talk about patient-centric medicine, from this point forward, in many ways, it's going to be up to the patients, because we have very few longitudinal studies. What does that mean? We don't actually serially measure how people change over time. So even if we know your genome and we know the genomic changes that might have driven some aspect of your disease, that's not going to help us much when we try to figure out what is it about that genome or the changes in the genomes and the proteins that we can actually look at early and start to think about preventing disease. So we need all of the patient data. We need these devices. We need you to keep track of, you know, on your phone. I mean, I don't know if you guys know about this, but you get your whole medical record in here. You can have, you know, what your nutrition is, what your sleep patterns are. Those are all things we don't understand. So in answer to your question, we don't know why humans do what they do. We'll never understand that. But we can understand when they do it and how they do it, and then relate it back to the changes in the genome. So a lot of things I'm doing relate to that, better clinical trials, more biomarkers that are standardized, and we can get them through FDA. All of that will derive from this convergence of mHealth and what we've been talking about up here, and what we're doing in the precision medicine space. So that convergence is critical.
Atul, there's the phrase today, and some people think it's an oxymoron, but is there a new breed of entrepreneurial scholars?
Oh, yeah.
Are you representative of that breed?
I think I am. I want to see more. If I had a simple request, it's to get more people in this field, whether they're high school kids, undergrads, graduate students, to be in this field. We're in the global conference, but we probably have more quantitative thinkers over in the hedge fund room than in this room.
Yes.
Healthcare is digital now. You can have fun. You can do this kind of work in this field too. We need more quantitative thinkers here, and I hope I'm not the first. I'm hoping I'm not the last, and we need many more in this field.
John, in a very short, compare working with people in the financial service industry and the medical area.
The people in the financial world are easier to work with.
Thanks.
You know, if you look at, you know, they all want to go make money, and they want to stand it. So if you guys in the financial world, you know, there are the fixed engine, the SWIFT, and all that, and you know, money transfer and you know, stock trading and option tradings are all well defined. In the medical world, you know, convincing everybody to go on one standard, virtually it's virtually impossible. It's just like arguing with your doctor. You always lose.
Patrick, how can we help you? There might be 1 million people watching this online. What could we do to help speed up your efforts?
Well, you know, I think, and thank you for asking that, because I think we are now probably, and everybody says that every 10 years, we're in the most exciting era of medicine and history, etc. But I truly, truly, truly believe we can now, for the first time, change the paradigm of cancer care. Let me just give you a very logical and illogical statement. There's this huge element now of companies, Juno, Kite, that's actually building systems to enhance your immune system. Fantastic results by building systems to enhance your immune system. 90% of the oncologists in the universe today are giving drugs, chemotherapy drugs, at maximum tolerated dose that's wiping out your immune system. Somebody's got to be right. And obviously we're not right if we're wiping out your immune system. So there is an opportunity not only to actually change the paradigm of care, of actually changing how you give chemotherapy to most effective dose that actually stimulates the immune system and then increasing the immune system. But more excitingly, and this is where I'm getting to, is to go after the cancer stem cell. Because I want to challenge the fact that the last 40 years, we've actually gone after the wrong cell. The cell that proliferates, which is the metastatic cell, almost is not the cell, it doesn't matter, but it's not the right cell to have gone after. That's why we've not won the war against cancer. What is counterintuitive is that the cancer stem cell doesn't divide. So all the drugs that we've been building that actually kills dividing cells don't go after the cancer stem cell. So here's a whole new world that we need to unlearn, but we've got all the tools. So one of my challenges is to go out to the medical community, the doctors, and the patients, to say, here's the tools that with the power of N=1, as we talk about, will completely transform not only innovation, cancer care. We happen to have in our hands patients with pancreatic cancer, stage 4 pancreatic cancer, that now have a median survival of 20 months and some 5 years alive without disease. Why is that? Why should it only be in a little cadre of patients here in Southern California? That shouldn't be. So the idea is we need to bring this as a global expansion.
So today we try to give you a look at the future in a digital age, moving big data and being able to analyze it the same as we have in other industries such as finance. And John, thank you for protecting our data. Thank you for joining us today.
Thank you.